So we're on week 6, guys. We are in the middle of the term. And as I said in the very beginning, it's going to start getting very hairy for you. We know next week is your exam. The following week, your pediatric assessment project is due. You also have a community project due. And I know you have a big med-surg exam coming in there too. So you've got it rough. So every day, use your time wisely. If you have a project that you've already started, you've done the paper, I've actually gotten some papers. Don't send it in the modules, send it to me in my email, and I will correct it, put it in proper format, send it back to you because you have a community paper, and then you're going to end up with a leadership paper, and you're going to end up with a mental health paper, and then you're going to have proper formatting as you go forward. Okay, I'm willing to do that. You just can't give it to me at the last moment. I can't do 50 papers on week 8, okay? But I will do that. Did you like doing the quiz at home when you wanted to? Do you feel that you learned more doing the quiz at home? Because then you could go back, look up concepts, and know the answers, right? The scores were great. I mean, whichever way you did them, as long as you're learning from them, that is a good thing. I think the adaptive quizzes tend to go towards what you need. It will change questions. So I like that. It's saying this is weak on me. So let me give you another question to ensure, yes, you understand it. So I like that. So today we are week 6, unbelievable. Yes, you do have another quiz that's due by Sunday night, 11:59 p.m. Eastern time. Okay, and then you do have a discussion question. No, excuse me, you have a case study, and then you also have your NCLEX questions. Make sure you look at the NCLEX questions. What are the subjects? And that's in the modules. Go look at the modules. It'll tell you what I want it on and do those. I was very pleased with the first set. That's usually the most confusing one because it's growth and development. You know, it's not pediatric section. I think one student did it incorrectly. And of course, I let them put it in and get it back. So good job for everybody for following directions. So let's go ahead. We are going to do hematology, immunology, and we're also going to do cancer. And in between, we do have a cahoots. This class runs about 20 minutes short. So you guys will be coming out a little bit early today because there's other classes you run a little bit longer. So this is one of your, believe it or not, your shorter class. So let's go ahead and start with the PowerPoint. Can you see that? Okay. So chapter 43, did that change for you? Thank you. All right, hematological, immunological dysfunction. These are probably some of the most common things that we see in children. Um, and it's very, very easy to diagnose these. We can look at a simple CBC, complete blood count, and we can tell so much about a child. We have a white blood cell count, which is going to tell us, is there an infection, bacteria, or is there a virus? We can look at the hemoglobin hematocrit. Are they anemic, right? And also we can look at platelets. And low platelets are going to tell me there's bleeding going on. So 3 things in a CBC tell us so much story. So we have a child coming in complaining of being sick all the time, or being complaining that their lack of energy, they're tired, they're not like they used to be, then this is something that's telling us, let's just do that CBC. Let's look at that hemoglobin. It sounds like it's anemia. We know as children become toddlers, they don't eat as much, they become picky, and they don't eat all the foods rich in iron. Think about what we do for the first year of life, the infants. We give them iron fortified formula. We also we also um, put iron fortified cereals. Plus, infants don't care if they have all these green leafy vegetables. They really don't mind any food. Put it in my mouth. I'm going to eat it as an infant. When we become toddlers, they are like, no, and turn their heads. All of a sudden, they stop. And they just want to drink their milk, which has no iron in it. So we've got to be careful with toddlers. That's that poor iron sources and the food because these children, that's give me the milk, don't give me food. Of course, if we see bleeding anywhere, all right, or infection, it's the CBC. So let's look at anemia. Anemia is probably the most common hematological disorder of childhood. I've told you, infants by about 6 months, their hemoglobins are really low because they have not started to make their own. So that's the first time we might see anemia. Then, of course, we making our own cells. Infants eat really well. So, of course, our hemoglobins build up good. Then we become toddlers and we're not going to eat the iron as much. So, again, we can become anemic. So, what is the thing with anemia? Why are we tired? Well, anemia means we don't have enough red blood cells. What do red blood cells do? It carries oxygen and iron nutrients to the cells. So if we don't have red blood cells, there's not enough oxygen. So hypoxemia, right? Also, no iron, no food. Cells aren't going to grow. It's not going to move. You're actually going to see delays in these children because they're not putting the gas in the tank that they need in order to function normally. Okay. So anemia, whatever reason why, it's that low hemoglobin, which is low red blood cells. We describe that in children as less than 10. I mean, in adults, will go a little bit lower. Now we get a kid in complaining of being fatigued, tired, don't look pale. You look at their gums, their lips. I look at ears, even nose, palms of hands. You can sort of tell if they're low, depending on what culture, what race they're from. Well, first thing when I hear these things is, believe it or not, I want to listen to their heart because you hear distinctive murmurs when that child is anemic. And the reason is this: those blood cells are filled, the vessels are filled, packed with red blood cells. When the hemoglobin or red blood cells become very low, they're not packed anymore. They bang off of each other. So you hear this sort of murmur because the cells are pushing everywhere. And now I know for sure this kid is anemic without even drawing my CBC. The CBC is going to say, yes, that's the proof, but I can also, from assessment, know it. Now, the problem with anemia in children is we need to fix it as soon as we can because the heart is a really unique organ, like the body. It tries to fix itself. So, what does the heart do when it doesn't have enough oxygen, enough iron, and nutrients? It beats faster, and then it beats faster, and then it beats faster, and then finally it gives out and you go into heart failure, right? So we don't want that to happen. And of course, no nutrition, you're going to see growth retardation, cognitive delays, and all of that. Now, there are different sort of anemias. Stuff that happens because you don't eat right. Some because red blood cells are lost, whether it is through nosebleeds or just hemovolemic, like you get cut sort of thing, or other stuff. And then there are some conditions of anemia where the blood cells are destroyed quickly. So they're not lasting long enough. So decreased red blood cell production, nutrition. There's two you need to know: iron deficient anemia, which is your green leafy vegetables, your dairy, right? Those things can help. And then B12. B12 is your intrinsic factor. Okay, it's in the stomach. The B12 one is an interesting one that we see. The symptom is that tender or sore red beefy tongue, and it looks like a big piece of beef in the mouth, and it's red, and the child will say it is tender. Now, sometimes when we have decreased red blood cell production, it's the bone marrow says, I'm stopping for whatever reason. It could be a cancer type thing like ALL, that of course does stop bone marrow production, Or it could be things like aplastic anemia. That's all sections of the red bloods of the CBC. We'll go into that in a second. But that is the bone marrow stops. Then we go into the blood loss. Well, nosebleeds in children are very common. Probably one of the most diagnostic tools when it comes into things like hemophilia, ITP, DIC. And ITP is ITP platelets, idiopathic thrombocytopenia purpura, platelets, P for platelets. And then DIC is just the worst thing that you can have. We'll go into that in a second. Now, increased red blood cell production is your sickle cell. Those cells die quick. They're in sickle shapes. The body don't like them. They die quick. So your hemoglobin always is on the floor when you get a child who's in a sickle cell crisis. I mean, if I see a hemoglobin of 7, I'm actually happy. Usually they're 5 and 6 requiring blood transfusions immediately. Thalassemia is the other one. I call them the rectangular shaped cells. And I will go into that in a second. And then, of course, we can have things like your chemotherapy, radiation, all those other things that can increase that red blood cell destruction. So let's go into the treatment. You get a child in who is anemic. Number one, you've diagnosed that because of the history. It's very clear. I'm fatigued, tired, they're pale, whatever, and we do a CBC. CBC is going to show the evidence. Hemoglobin hematocrit is going to be low. Now, depending on how low it is, we need to help the heart right away. So they need a transfusion. But we are correcting a symptom, not the cause. Okay. Why was those red blood cells low? Was it due to nutrition? Was it due to something else? The one thing we will do always, and I'll mention it again, is a stool for occult blood. Don't assume that it's just anemia. Okay, that's the one thing you need to always rule out. If it's, we're given the transfusion, of course, and we're finding out it's iron deficient anemia, we're going to be starting to given that diet that we need, of course. But we need to, number one, fill up that blood vessels. That is with the blood, that is with IV fluids. They also get oxygen. Now, it's controversial, believe it or not. You don't have red blood cells. Is it going to carry more oxygen around? Is there more? Is it possible? Not really, right? But we put it on because we think it helps, maybe. But I think the biggest thing is this kid's tired. He's fatigued. He's got low hemoglobin, bed rest, cluster cares, everything to decrease energy expenditure. When we're looking at the kids, we can look at what's going on, right? How old is the kid? Makes differences. The racial ethnic background, African American, sickle cell, from the Mediterranean Sea area. That's thalassemia. I mean, these things, knowing it, will point into maybe what it could be, right? And of course, that stool for occult blood, let's rule that out. Always let the kid know what's going to happen next. If we're telling them that we're suspecting this and we need to draw blood, let them know what they're going to do. And again, do everything to minimize the stress and the pain of that blood draw, okay? Using numbing cream, sitting on mommy's lap on their developmental level. Those will always be included in exams on pediatrics about getting on their level, so that we could get things done easier. And when we do that, this child now is well prepared. So we're not going to see them fighting and screaming and burning up any little energy they have left, right? So that's what our goal is. So iron deficient anemia, most common of all of them. What is it caused by? It's caused that the child's not eating the proper foods with iron in it. That's why we have iron fortified formulas. That's why there's special formulas for the smaller infants. And the other thing we don't think about is adolescents. Remember adolescents, they're into body image. Girls and boys are too fat, they need to lose weight, they're not eating properly, or they want to save their money to go out on the weekends so they don't spend their lunch money. So they get a power bar and a bottle of water, and that's their nutrition for the day. So adolescents are actually at high risk for anemia. We also know that anemia in those kids as they get older is that milk baby. They're drinking too much milk, and which has no iron. Yes, as calcium, vitamin D, but there's no iron there, which is the most important thing. And these children, again, become iron deficient and anemic. So, how do we treat it? Number one, diet. Prognosis is great once you replace the iron, and we could give iron supplementation. Do you remember how to give oral iron to a child? Number one, iron has to be digested and made usable by the stomach acid. So we need to give iron, liquid iron, through a straw so it doesn't stain the teeth on an empty stomach with orange juice because it's acid. It helps break down that iron and make it usable. And please tell those parents the stool's going to turn black. I've had parents come out screaming with black stools in their hand because the kid had iron, and it's not a pleasant thing for those poor parents. So, sickle cell anemia, if two parents, each parent has a trait, every child, 1 in 4 or 25%, have a chance of having the disease. There are many people who run around with a trait and it does nothing, has nothing, but they can push it on and carry it on to their children. That's the thing about sickle cell. Okay, what is sickle cell? So, sickle cell are these really weird shaped cells. They're like little C's, sickles, right? And what happens is as they flow through the bloodstream, they get to a smaller bifurcation and a sickle cell gets stuck. And it can't get through that bifurcation. And cells back up behind it, pack up, and then it becomes swelling, and then it pushes out into the tissue and creates pain and swelling and redness, and it hurts. So, what caused that sickle cell to get stuck? It's because the blood vessel wasn't big enough for it to get through. So, one of the things, biggest teaching in sickle cell is to keep fluids on board. You need to keep well hydrated. If you're in cold, you need to put on warm clothes. If you're going up in an airplane with pressure, you need to drink fluids. If you're going up in mountains, drink fluids. If you're out playing sports, drinking fluids, drinking fluids. So, what causes sickle cell attacks? Well, number one, it's that lack of fluids. And so, what are those things that can cause that? Well, what if you had trauma, a crush injury? Of course, that's the swelling that's going to cause sickle cell crisis because blood can't get through. Infection fever, you're losing fluids, right? Physical, emotional stress. Again, you're not eating, you're not drinking properly. And again, dehydration, fluids, being out in the heat, not drinking. You need fluids, and that causes hypoxemia and again, death of tissue. And of course, that's going to cause that pain, and they'll go in for that crisis. So you get into the emergency room. Okay, you're in a lot of pain. Let's say it's your knee. It's just swollen up and it hurts. You fell down. What do I do? Well, first of all, we need to take and hydrate and give the fluids in there and give something for pain. And we put oxygen on. So, oxygen, pain, and fluid management is what we need. We also, because it's the knee, we can get to it. Let's put a warm pack on it, right? It'll dilate the area. Again, trying to correct the cause of sickle cell, not the symptom of pain. So let's dilate those things. Sickle cell children are actually, because they are immunosuppressed, they are given prophylactic antibiotics for the first up to 5 years of life. Well, and it's usually PenVK is usually the name, a penicillin pill once a day, and it does help. They also monitor their retic count, see what's going on with that. And of course, sickle cell. These children's cells die quickly. As I said, these kids come in crisis into the ER. If they have a hemoglobin of 7, I'm actually very, very happy. It's usually 5 or 6. They come in and they're so pale, they're so weak, they're so much in pain. It's like you got to put oxygen on. Let's give them something for pain. Let's give them fluids. Let's get the blood in quickly. And again, once we do that, and that's all done in the emergency room, by the time we get that child sent up to the ICU or floor or wherever they're going, they're already feeling better by the fluids, by the blood, by the pain medicine. Now, sickle cell, there's no cure. They think maybe a bone marrow transplant might help. I've seen some reject and I've seen some work, so either or. But the big thing that will kill immunosuppressed children, sickle cell or anyone, is fevers. I said they're immunosuppressed. That means there's no immune system. Any patient, any client that has a fever of 100.5 and higher must seek medical attentions immediately, because that 100.5, that low grade fever, can turn into septic shock very quickly because there's nothing in that body to help prevent that child from going into septic shock. There's no immune system. Okay. That's why bacterial infections are the ones that will kill these kids if they don't get into ER quickly. We know kids can live normally and happily, but they've got to make sure that they're up to date, get treatment early, keep hydrated, and of course, always treat pain before it gets too bad. These kids do get pain pills to go home with because they know once they start with pain, they need to take something and then get to help. So, what do we educate our kids about? Sickle cell. Number one, early intervention. As soon as you have a fever, as soon as you have pain, take care of it, do what you need to do. The penicillin, if they're still taking it, make sure they take it every day. Why did I put here recognize signs of stroke and respiratory problems? Sickle cell attacks can be in the brain and could mimic a stroke, which is a stroke. So that's serious. That needs to be declotted immediately. We need to get blood flow to the brain. Also, respiratory. Could it be like a pulmonary embolus sort of pain? Or maybe it's something in the heart. So again, these are the emergent, right away, tell the doctor. Normal things, swelling hands, pain, those sort of things are normal. We expect them. But stroke and like problems with breathing or sudden onset chest pain, these are serious. These are the one we tell the doctor right away. Now, thalassemia, this is what I call rectangular shaped cells. These rectangular shaped cells are from people, descendants of the Mediterranean Sea. And thalassemia is where these cells burst early, they die quickly. So, what's inside a red blood cell? Iron and oxygen. So, if I'm bursting all my cells quickly, I am putting iron and oxygen in the body. The iron becomes toxic and I need to treat it with either an iron chelation medication or an apheresis, which is like a dialysis, but it will just take off iron. It's a really specific little thing. Nurses run it. It's a really neat little machine. Looks like dialysis machine, but a little bit smaller. And then, of course, oxygen, we're going to put oxygen on that child because that's being spewed and you don't have all the cells. So, there are 4 types of thalassemia. You don't need to know all 4 types. When we discuss thalassemia, we always discuss thalassemia major or Cooley's anemia. Now, the other ones are mild, watch, sort of. We do different things, but what we want you to know about thalassemia is these cells die quickly. There's no oxygen, there's no iron. It's all spewed into the and vascular, and it's not working for that child. So this child to live has to have transfusions. Can you imagine? You go from no blood cells because your body has spewed them out. You go in for your transfusion and you get your transfusion, and now your hemoglobin's up and your heart rests. And then you lose your cells, and now the heart works a lot. And then you give it transfusion, and now your heart's fine. So you're stretching and you're like up and down this heart failure is usually the big thing with this one. When do we diagnose thalassemia? What do we know? It's not like sickle cell that we can look in traits and whatnot. It's just something that we're going to see in the red blood cells. Now, at birth, you got mommy cells, so we don't really see them. It's usually around when you start making your own cells. Now, they say the cells start changing about 6 weeks, but it's usually about 6 months where those baby cells are now making their own. They're making now rectangular shaped cells. And now you're seeing a child who's anemic. They're not getting oxygen and iron, so they're going to be cognitively delayed. They're not going to meet their developmental milestones. And that's going to be the first clue, that lethargy, not meeting milestones, which makes us go look at the cells. We do a smear, we see the rectangular shaped cells, and now you're diagnosed with thalassemia. They need to get, as I said, that iron chelation drugs or apheresis to get rid of that iron out of the body. They need transfusions to be living because they're not making their own cells. And many times they'll just take their spleen out to stop those cells from being done. So, care management, thalassemia. You need to make sure that they're getting their transfusion and whatever iron chelation therapy they're on, making sure that they are doing it because iron is toxic, will end up in seizures and death. Okay. Also, these kids are in and out. They're getting transfusion. They're always with needles. Can you imagine? Making sure we get this child very well. How does he cope with it? What are we going to do to help him? And try to explain things as best as we can and minimize that stress because this is a lifelong illness. It's not something that's going to be cured and go away. Also, we have a family that now is a child who is now becoming anemic all the time and becoming hypoxic and doesn't have energy, doesn't have iron. This family has to deal with that also. And we know blood transfusions, when we are giving them all the time, chances of all of these complications get more and more at risk. Every time we give another blood transfusion, there's antigens and all these things that could be in the blood, and now they're a rare type, and it becomes quite a thing if that happens. Now, if we treat these right, if they are getting their transfusions, if they are, taking it easy when it's, their hemoglobin gets low, and if they're doing their iron chelation therapy, they can live up, into adulthood. Usually, they decide to go ahead and take their spleen out, right? Post-splenectomy sepsis is a big thing. Again, there's no immune system. There's another autoimmune, immunosuppressive sort of condition. We know the heart's working like crazy. It's working a lot, not at all. Working a lot, not at all. So that heart is so confused. So heart disease, sepsis, and then of course all the organs. You're not getting oxygen. They're not got nutrition. Multi-organ failure. Again, maybe bone marrow's a cure, but we're not sure. So aplastic anemia. Think about pancocytopenia, okay? This is everything in a CBC. It is profound anemia. You have low hemoglobin hematocrit, leukopenia, low white blood cells. They're up to get infection easily, right? And thrombocytopenia, low platelets. So they're going to be bleeding. So this is a little bit of everything. We treat this just like leukemia. Just like leukemia, we give immunosuppressive therapy, bone marrow, and that's usually the way that's done. It's over a course of time. I'm going to go into leukemia next chapter. So let's talk about bleeding when your blood doesn't clot. Whether it's clotting, whether it's a factor, whether it's platelets, let's look at it. So hemophilia. This is a condition where one of the factors that make blood clot and stop bleeding isn't working. We have factor 8, we have factor 9, we have von Willebrand, and then we have all other things in the blood like platelets and prothrombin and all sorts of things that help with bleeding, okay? Hemophilia is usually comes from mommy. 80% are X-linked recessive. So mommy hands over this lovely little gene here. We have three types mentioned here. Most common is factor 8. We call that hemophilia A. Most people are factor 8. Hemophilia B or Christmas disease is another factor, or factor 9 is missing. And then there's one called von Willebrand. And this is not a factor 10. He named it, the scientist, and the scientist's name was von Willebrand. And he also said it was with factor 8. So it's both of them combined. So these are missing things that make you bleed. So how do we diagnose hemophilia? Well, we're seeing bleeding somehow. Many times when we see any of these issues about bleeding, it's usually epistaxis, and it's not one nosebleed. It's like 3, 4 in 2 weeks, like a little bit excessive and a lot of blood coming. That's sometimes that makes us just draw a simple CBC to look at platelets, okay? Also, any sort of swelling in the joints, blood, hemoarthrosis means blood inside the joints, like falling on the knee and the knee swells up with blood, or the elbow. And of course, ecchymosis type things, big bruising, something's going on there. So we know that drawing these factors, they're send out labs. They take a week or more to get those lab values back. Not every laboratory has that capability. So when we are in the doctor's office or the ER urgent care and we're trying to diagnose this, what we're going to do is a CBC and a PTT, right? That's your bleeding coagulopathy, the easy one that we can do. So when we do the labs, we know that we are going to see a prolonged PTT. We don't got factors yet, so we don't know it's hemophilia yet, but we see a prolonged PTT. When would you have a prolonged PTT? If you were on aspirin or Coumadin, or not Coumadin, but heparin, these prolong your PTT. If there's no reason for it, that's suspicious. But when we look at it further, platelets are normal. Those are the first things that we look at. So how do we take care of hemophilia? Well, I had a little boy who came into my ER one Saturday morning with daddy. And he actually had fallen down on his knee, and it was hemoarthrosis. It was big and it was bruisy and it was painful. And he had called his hematologist to see if he should be giving the factor at home, because they did it at home all the time and they couldn't get a hold of him. So they decided to go into the ER and ask a physician. Well, our doctor said, yeah, go ahead, give it. So the daddy said, do you mind if I give it? My son's used to it. I'm like, I have no problem with that. Can I watch you? Because I had an orientee with me, a brand new nurse. And I wanted this nurse to see that parents are very capable and able usually, but still I want to watch. I'm telling you, this gentleman washed his hands, laid out his equipment, used alcohol swabs. The son picked a vein, put on the tourniquet. It was a butterfly with a connection with a syringe on the end. Put it in, gave it. The kid held the butterfly. It was the most beautiful thing I've ever seen. And the father and the son did it together. It was lovely. I really taught this new nurse something that you can use, parents. They can help you. Now, if a kid is home and falls down and hits his knee, there are certain things that we need to do. We do these for sprains too, right? You get a sprain, you stop, you rest, you ice it, compress it, and elevate. Now, when we say hemophilia, we put the P in front. What if you have a brand new toddler just diagnosed with hemophilia and they're wobbling all over the house? You need to protect that toddler. Sharp edges of coffee tables, sharp edges of dining room tables or chairs or whatever. You are patting everything. Protect, 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 right? Our biggest thing with hemophilia is that if we are falling down and we're getting blood inside joints, it is caustic and it can destroy joints. So our goal is to decrease that bleeding, stop it as soon as possible so that we don't have long-term crippling effects and end up in wheelchairs. That's our biggest goal here with hemophilia. And these kids can be normal. Now, they're not going to be playing football, contact sports, but they can swim, right? They can do other stuff, not a problem. Now, immune thrombocytopenia or immune thrombocytopenia purpura, ITP, ITP for platelets. What happens in ITP is a kid was sick, usually some sort of upper respiratory, some infection was going on, within that month. And all of a sudden, you start to see, usually it's nosebleeds. This is the one that absolutely nosebleeds. It's the third one this week. So we want it looked at. And then we looked at the body and we saw petechiae and hematomas, and we're like, ecchymotic areas. And mom goes, this kid doesn't go out to play. I don't know why he's bruised. I don't know what's going on. Is he getting abused at school? I don't know. I mean, that was her concern. Well, we did that good old CBC, and guess what we saw? Platelet counts of 12,000. And 12,000 means that this child is going to bleed. Now, we can fix ITP usually. But if it goes on for a year, then we'll just say it's chronic and something that needs to be monitored and treated occasionally, periodically. But the treatment it's all supportive, okay? Let's look at the bleeding, see what's going on. But it's IVIG, it's intravenous immunoglobulins, also anti-D. It's another one that they give with it. As a nurse, what are you monitoring? What's nursing care? Well, number one, it's a lot of teaching. This is a child who has low platelets whose chances of bleeding are great. Brushing teeth, soft toothbrush, no shaving, right? Being careful of injuries, all of these things we need to teach this child. Also, as a nurse, you're not going to stick a needle in anywhere, no venipunctures. You will be doing usually daily CBCs, but we usually will take that out of an IV so that it's one stick, the IV's in, and we don't have to keep sticking that child. And you need to find out, what are those lab values? Where is the platelet count today? Oh, it's up to 32,000 today. Okay, our treatment is working. Another thing, it says here sometimes corticosteroids. I've seen it used every single time. So corticosteroids and ITP does help. Now, I've mentioned epistaxis or nosebleeds a couple times. This is actually one of your NCLEX questions that you're going to see. I've been told repeatedly that it's there. How do we take care of a nosebleed? There's been, the old-fashioned way and the way it should be. Take your thumb and forefinger, put on the bridge of the nose, and squeeze it. And you lean forward. They used to say, put your head back. If you put your head back, you're going to be swallowing all that blood and you're going to vomit. Lean forward. If you need to, the blood can get them out of the mouth. Hold it for 10 minutes. Once the 10 minutes is done, you release. If it's still bleeding, you need to go get medical care. How do they treat nosebleeds? There's actually two ways. I've seen what we call nose tampons, which look like tampons and they swell with the bleeding, so it puts pressure in there. So it's like putting a finger on a bleeding place. Or depending, they might go to the OR and cauterize it. It depends on severity of it. That's just for you to know. Now, HIV/AIDS. We think of this with newborns born of HIV parents, mother, and we also think of that with adolescents and risky behaviors. Those are part of the pediatric thing. We know that HIV with the newborn, if the mother is getting proper medical care, proper prenatal care, that by 22 weeks, they can start this HART therapy, which is highly active antiretroviral therapy. And what that does is it starts giving this infant what it needs to improve their immune function. Okay, it's all about everything we do for an infant born of an HIV positive mother is to improve their function. Now, you're going to say every baby born of an HIV mother, because of the blood thing, they're all HIV positive. No. We had triplets born. One had AIDS, one had HIV, and one had nothing. She was fine. I've also seen babies born of HIV mothers, and at 1 year they convert and they're not anymore. So, again, very important in the newborn infant, your goal is to improve that immune function. And that's through those antiretrovirals, antivirals, and giving them from birth, making sure they have every opportunity to fight that virus off. We know PCP pneumonia is the most common of the infections. Again, that's lungs, that's respiratory. It's a very serious thing. So let's see. We know when we're talking about children and adolescents and HIV, again, if we're giving them information on, birth control, it's also to mention being protecting from HIV and, using condoms, et cetera, et cetera. So when we're working with children that have hematological or immunological dysfunction, how do we treat it? Well, as I said many times, we're giving blood transfusions. There's different types. We have packed cells and we have whole blood. One of the things that you need to know, whole blood is only given when you need volume. You wouldn't ever give that to a person with a cardiac problem, respiratory problems, or elderly and frail. No, that's whole blood is a gunshot wound. You need blood in quickly. Packed red blood cells are less volume and more cells. And this is what we use for your patients, adults, children that can't tolerate all the volume. And we know children don't tolerate volume. So they always are getting packed red blood cells when they get their transfusions. We know that there is always a chance for blood transfusion reaction. We know the first thing that happens, I'm telling you, the one that I've seen all the time, most of the time, for blood transfusion reactions is a fever. And it's usually you check your blood, you do your set of vitals, you hang the blood, and 15 minutes later, they do another set of vitals. Usually that's the fever. And it's usually 101. That's when we start seeing it. So that first set of vital signs is important. Always follow hospital policy with giving blood. It's actually a pretty scary thing. It's not just hanging blood. It can be quite a fiasco if it went to the point of transfusion reaction. The other thing that we do with these sort of conditions is possibly a bone marrow transplant. I think I have it down here 16 times, but anytime you're going to do something that's going to hurt, Please be honest with that child and let them know what's going to happen. Kids want to know. Don't lie to them, but just say, I'll do everything possible to make it the best I can and hurt as least as possible. That's all a kid wants to hear. So when both parents have a sickle cell trait, what is the chance of each of their child having sickle cell anemia? Anybody?
25%.
Yes, thank you so much. All right, let's go to our first Kahoot. Who wants to win this one? Mackenzie does. I know you do. Martina does too. I see you
I
over
never
there.
I never do, but I like to think I can one
You
time.
know, on my Tuesday night class, I had somebody who never wins win. So there you go. Can you see that? Let's get going. Hematology. What is priority treatment for a newborn for an HIV positive mother? What's our goal with that? What's our priority? I've got a baby born. Mommy's HIV positive. So, who wants to give antibiotics to a virus? Just to let you know, this is always a trick question. It's always going to be there to trick you on SC and NCLEX. Remember, viruses, there's no antibiotics. So, if we can't give antibiotics, what we want to do here is to boost their immune system so they can fight it and become negative, and they can convert, as I said. Kind of hematocrit with someone with sickle cell have and why? So, sickle cell. They are sickle-shaped cells. They die quickly. These are children, I said, they come in crisis. They're pale. They can't hold their head up. They've got hemoglobins of 6 and 5. And these kids, they die quickly, these cells. So again, sickle cell always have lower because of this. Let's think about the type of cells. They don't really make much of anything, so they have to be lower. What is the nurse's priority with a child with sickle cell disease who is currently experiencing crisis? So when we have a child with sickle cell, yes, we're putting on oxygen. Yes, we are giving pain medicine. But how do you relieve the cause of sickle cell? That's by dilating the veins so that the blood can flow through and can get that little pack up, that, dam. Let's open it up and get it moving again. So that's why we're going to give IV boluses. Let's dilate the blood vessel, put the hot packs on, dilate them some more. Oxygen just to help with that little bit of cells that they have there. What is the reason children with iron deficient anemia are easily tired? So, iron deficient anemia means you don't have enough iron. Where's iron in the body? In the red blood cells. So, you don't have enough red blood cells, you don't have enough iron. You see how you think here. Good. Multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? Take it on an empty stomach, take it with a straw, take it with orange juice, and tell them it's going to turn black. We never take it with milk because that coats the stomach and then it won't be absorbed and it's useless. And we take it after meals. No, we need a nice empty stomach to do it. Good job, guys. Aplastic anemia includes a depression of which blood cells? I say it's this, that, and the other. I think of all of the anemias. And again, treatment, we treat this just like we would a leukemia. This is when you see red blood cells, white blood cells, platelets, they're all low. This is a very sick, very weak child. Most common type of anemia is iron deficient anemia. Very good. Glad you got that one. Causes promiscuous anemia. B12 deficiency. Yes, it is. And what's the symptom of B12 deficiency? Pernicious anemia. It's that good old tongue. It looks like it's sore, but it's red and beefy looking. It's like this bright red. It's very distinctive. Seen one. What symptom is the single most common symptom of anemia? Fatigue. If you don't have iron, you don't have oxygen, you don't have energy, you don't have food, you're not going to move. You're just going to sit there. You're exhausted. Fatigue. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Thalassemia, rectangular shaped cells that die, burst quickly. What are they at risk for? Mediterranean Sea people. So remember, what's inside a red blood cell? Iron and oxygen. It bursts. It's in the inside the blood vessels now. So you're hypoxic and you have too much iron. So you need medicine to get rid of that iron, and of course, maybe some oxygen, and you need a blood transfusion to get the hemoglobin back there. So I keep asking these to remember you, to remind. What lab values will you see with hemophilia? Hemophilia is a bleeding problem. It's factors, and there's other things in the blood that you see. And we'd see them prolonged because the blood is thin, it's not clotting. So hemophilia, you're going to see a long PTT. It's just like you've been taking heparin, and you're going to see one of those sort of things. Usually it's what, 40 to 60. You're going to see it well over 100, 150 sometimes. The PT platelets, these are all normal things. What is immune thrombocytopenia purpura? ITP? ITP, P for platelets, low platelets in the blood. So I try to give you the little jinglingles. ITP, P for platelets. You don't have platelets, you see petechiae, you see purpura, okay? Thrombocytopenia can cause the following symptoms. So thrombocytopenia, ITP, many times they're going to come in with nosebleeds. In fact, that's usually the symptom they come in with. And then when we inspect them, we see like purpura on their legs, or we'll see some bruising, ecchymotic areas when we go looking, and the parents are like, "Ooh, look, where did that come from?" And they're like worried of abuse at that point, which we know it's not. Bye. A child with hemophilia has fallen and the knee is swollen and painful. Treatment would include what? So we know initially a kid falls down, sprains the ankle, anything. It's rest, ice, contain, and elevate. That will be also week 9. You're going to hear rest, ice, contain, elevate. That will always be the injury, especially hemophilia. We want to decrease the amount of swelling in that joint because we don't want to take that joint and get it full of blood. And now we've got a crippled joint. We don't want that. What is the priority nursing action for a suspected blood transfusion reaction? Whenever leaking IV, reaction, anything, number one, always turn it off. You can always turn it back on if it's not that, right? But again, anything you suspect, turn it off. Better safe than sorry. A child is admitted with neutropenia. What nursing action takes priority? What does neutropenia mean? So, neutropenia. This child has a low white blood count. What does that mean? That means they have no immune system to fight infections. So, nursing responsibility, wash your hands. It's as simple as starting there, okay? Trick question, right? When distraction is used, it helps what? So when you use distraction in children, they're probably sitting there crying or whining or something's going on or they're in pain. What you do is you refocus their attention on something else, something that's happier, and it takes that mind away from it and it will help you be able to treat that pain if that's what it is easier or stop that fuss for that moment. What assessment question needs to be asked to a child with possible rheumatic fever? This was from last week. I'll always throw these in. You need to know what rheumatic fever is. What causes rheumatic fever? It is a strep throat that was not treated or not completely treated. And then rheumatic fever can occur, right? Signs and symptoms of asthma. What do you see if a kid has asthma? Remember, asthma is a reaction to an antigen or allergen in the environment, and it's all about the lungs. And the first thing they do is they start coughing, 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 coughing. And then they get very, very short of breath. And asthma is a lower respiratory problem. That means air gets trapped down there. So they can't push it out. So we have this expiratory wheeze trying to get the air out. Croup is inspiratory on top, but asthma is on the bottom. I can't get it out. It's expiratory wheezing. Multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Which one of these are scary that needs to be now? Not just the normal type of symptoms, but stuff that really warrants further investigation. So swelling is normal. We would see that swelling of the fingers, arms, knee, elbow, whatever. All of those could be, but it's the headache, which could be a stroke. Chest pain could be pulmonary embolus, could be a heart attack. These are things that need to be investigated more. The other two, sort of normal. We sort of expect those things. The other two are more emergent. What are the odds two sickle cell carriers would have a kid with sickle cell? Mom and dad have the trait. 25% kids, yes. Position for a lumbar puncture for an infant or a younger child. So we call it lateral decubitus. Older people can maybe, sit up over, the bedside table or a pillow. But, young kids, we like them on their side and I can hold them so they won't move as we're just touching them and tickling their backs. Lateral decubitus, important one. Hodgkin's or non-Hodgkin's diffuse cancer of the lymph nodes. I put this question here and you're going to see it again in the next set of cahoots. Hodgkin's is a cancer that is a Hodge, it's a lodge, it's a house. You can see it and feel it. And it's usually above the shoulders. Usually you see these big things in the neck pushing against the trachea, creating airway obstruction. Non-Hodgkin's, you don't see a house. There's not a house. It's not a lodge. I can't feel it. I can't see it. It's more like embedded inside. So, and it's more lowered below the shoulders. So Hodgkin's lymphoma, I can see it, feel it, touch it. These are non-tender lymph nodes, usually in the neck that we see. It pushes the air pipe, and that's when they start coughing. But up to that point, it doesn't hurt. And again, non-Hodgkin's, it's not. You can't see it. It's not a house. It's not a lodge. I can't see it. I can't touch it. It's inside. It's deep. You need to know the difference. A Wilms tumor. So Wilms tumor is a nephroblastoma, a kidney tumor, or it's a tumor in the kidney. The biggest thing about Wilms tumor is a very fragile encapsulated tumor, and little minimal touch can break off pieces and causes metastasis. So do not touch that belly. Do not palpate the abdomen. That's the whole thing with Wilms. They don't even do a biopsy preoperatively to get it out because they don't want to put a hole in it and let it get out. Child with a Wilms tumor, which action by the nursing student causes faculty member to intervene. Right. We do not want to touch that abdomen. When we get to that, and the next thing I want to tell you a story about a little boy that I met. Absolute contraindication for nasal tracheal suctioning include the following. When do you want to suction in the mouth? Oral airway. When do you want to leave it alone? Is basically what it's saying, right? Whether it's croup inflammation, epiglottitis inflammation, tonsils post-op surgery inflammation, leave it alone. Keep everything out of the mouth. Iron dextran is given via which route? This was my first injection as a student nurse. I gave iron dextran. And I gave it, she was like a 42-year-old woman. So a young woman, not even old lady. And it is IM Deep Z Track. So my first injection, not only just a regular IM, I had to Z track it as I did it. Actually, she told me I did a good job, or she lied because she knew it was my first one. But again, IM Dextran, we give Z track because it burns and it stains the skin. That's why. Patient teaching for administering liquid. So again, orange juice. The stool's going to turn black. Drink it through a straw and always, always on an empty stomach. Good job, guys. What cancer may present with painless, firm, and enlarged cervical nodes? And that's your Hodge. That's your lodge. That's your house. I can feel it, touch it. As I said, they're big looking things. They look like they would hurt, but they're painless. The problem is they get big and push against the throat, causing coughing and choking and even vomiting at some points. So Hodgkin's lymphoma, above the shoulder, cervical. Supraclavicular is the other word. When teaching about sickle cell disease, you would include So sickle cell disease, you never limit fluids. Very good. We want to force fluids all the time. We want to keep them warm if it's cold, take medicines when they can. And any immunosuppressed child, sickle cell, cystic fibrosis, anything, any child immunosuppressed need an adult needs to seek medical care for temperatures greater than 100.5. There is no immune system. They need help. They need antibiotics now. Thalassemia major is treated primarily with what? So thalassemia is when those rectangular shaped cells, they're bursting. So there's no red blood cells. We treat it because this is the major or Cooley's anemia. We treat it with blood transfusions. Yes. Last question. What is the most common opportunistic infection for children with HIV? And it's PCP pneumonia. I mean, a lot of it do get candida, yes, but the big thing with the opportunistic is PCP pneumonia. I mean, me and you, it's no big deal, but for HIV patients, it is. Number three, got a monkey. Number two, we have an Ash. Good job, Ash. Number one, nah, good job, guys. Number four, an SK and a Mimi. All right, let's go and continue. Any questions so far? Can you see that? And did it move? Beautiful. Thank you so much. Okay, cancer in children. Most of the children's cancer are basically leukemias and lymphomas. We don't see more of the solid tumors, more is leukemias and the lymphomas. So let's look at leukemia. Leukemia is more in boys. It is usually about ages 2 to 5, which is, really horrible time for parents to say, my kid has leukemia. They're just toddlers, right? They're little kids. But look at these Down syndrome children. Not only are they apt for congenital heart defect, they also are higher risk for leukemia. Hypothyroidism is another one that we're going to get to. It's like these poor children. Think about a kid who can get anything, a Down's child. So, leukemia is an unrestricted proliferation of immature white blood cells into the blood forming tissues, which means we've got these cancer cells being, white blood cells, you don't have an immune system, you have nothing to fight infection, and that is leukemia. Now, what do we see with leukemia? Well, I had a next door neighbor. Actually, it was a girl that my family was, we went to school. She, rides to school back and forth, her parents and me. And this girl one day wasn't feeling well. She had flu-like symptoms. She had a little fever. She felt like she had pain in her knees were killing her. The pain was terrible. And she noticed that she was bruising that wasn't normal because she wasn't one that was very physically active, right? So she went in to the emergency room. When she went to the emergency room and they heard these symptoms, they did a simple, that fatigue thing, they did a CBC, fatigue fever. It's going to show hemoglobin and it's going to show infection, white blood cells, right? Well, they also did a blood smear and it shows those immature leukocytes, okay? Normally, leukemia, you're going to see low white cells, low red cells, and low platelets. All three are going to be hit with this one, just like aplastic anemia, right? All of them are going to be hit. So we also, after we figure out, all right, it is leukemia, is it leukocytes or monocytes? There's two types, right? We have ALL and AML. The one that's easier to cure is ALL, just to let you know. So once we determine this, we do a bone marrow biopsy. We want to make sure that the central nervous system is clean, right? And of course, when we do this bone marrow, always tell that child it's going to hurt. You be honest so they know it's, you do everything to make it as little as pain as possible. Now, there are ways that we treat leukemia, and there's four phases, and it's all about the chemotherapy that we're going to use. Number one, we put in a central line. Usually it's a port, which means it's under the skin so that when they go home, they don't have things taken out that could be pulling, especially on the younger kids. That's important. So it's underneath the skin. And initially, what we do is what we call induction therapy, the most important part of the therapy. It's 4 to 6 weeks, and they hit this child with very heavy chemotherapy agents. And the goal is remission. You're going to say, but remission after initial? Yes. Now, they go on, they do the central nervous system. Yes, they do a consolidation. And yes, they do maintenance. This is just to make sure there's no little outliers out there hiding. So they make sure all the cancer is gone. Now, sometimes leukemia with chemo doesn't work. And what they need to do is give them a hematopoietic stem cell transplant, bone marrow. They need to give it to them. So there are different types. Sometimes at birth, mommy has taken your cord blood and put it in the bank, right? It's expensive. A lot of parents can't do it, but some do. And that would be considered automatically mine is the best, autologous. Automatically mine is the best. That is previously stored cell. Usually we consider that as cord blood is usually what it is. Yes, they can have other ones for other reasons, but usually it's that. And then there's all the others, allogenic, all the others. Now, of all the others or allogenic, siblings from the same parents are your next best one to be able to be given. And we know even with bone marrow transplants, you can have a reaction, a rejection, host versus graft type thing. I've seen it. So you have a child who has leukemia. There is going to be a long-term treatment. They're in and out of the hospital. We have a port. We're always, accessing it. They're always getting something done. They're not feeling well. They're nauseous. They're this. They don't want to eat. They've got all this stuff going on. So, number one, make sure you prepare that child and the family what's going to go on. Again, get on their level, making sure that they do understand. As I said, my next door neighbor did have a lot of pain. So make sure that you do relieve the pain, no matter where it's at. We know that we're going to see low white cells, low red blood cells, and low platelets. So we've got to be concerned about infection, right? Washing hands would be, or wearing gloves, or wearing a mask, depending on hemorrhage, being careful, soft toothbrushes, no razors, monitoring the skin for ecchymotic areas and petechiae. And then anemia. I'm tired. Let's cluster care. She's going to be tired all the time, right? These are things we need to think of when we look at those things. And of course, nurses using chemotherapeutic agents. Do you know there are having sign on bonuses for pediatric chemotherapy or very adept with it or certified, like $25,000 sign-on bonuses for like 1 year, 2 year commitments. This is a hard area to work, but it's also very rewarding too. I mean, in any area of nursing, not everybody's going to live, right? I know it's harder with children, but children give you so much more than you could imagine. I loved working with them. So, prognosis for your chemo and your leukemia. Well, actually, what it has to do is what was that white blood cell count? Now, on Mig Young, which was my next door neighbor, she was a Korean girl, her initial white count was zero point 0.1. I've seen them low as 0.01. That low is going to be harder to cure than the one at zero point 0.1. So that's one of the determinants. How old was the child? Younger kids do better than older kids. And was it the ALL or was it the AML? We know ALL is easier or less difficult to cure. Boys and girls do better than boys. And then karyotype. What is their blood type? Is it a very rare type or is it A positive like everybody else in the world, which means I can get any blood I need whenever I want. But if I was a very rare type, when I needed blood, I may not be able to get it, and that will make the difference. So, cancer, how do we treat it? Well, usually it's a combination thing: radiation, chemo, surgery, all of these things. And we know today there's all those specialized nurses, IV nurses, everybody, in order to take care of these kids, they have their specific duties in order, like who's going to access the port, who does it the best, make it easier for the child, who's going to do the sedation for this and that. These children, these experienced nurses know these kids. So when we were talking about a kid with cancer, the detection early is what we needed. I mean, my next door neighbor, she didn't feel well. And it was to the point where her parents said, well, we don't have insurance, but we're going in there anyway. I mean, that's how sick that she felt. And she did. She had pain, fever, ecchymosis, and she had petechiae. That was all of her symptoms. And she had flu-like symptoms, which was the lethargy. And of course, weight loss because she didn't feel well. I don't know about the lymph nodes or whatnot, but even vision change can be a big thing for these children. So making sure that they knew what their symptoms were can help with early treatment. Now, when we're given chemotherapy, what we do is we wipe out immune systems, right? So we know at certain times during giving chemotherapy, there is no immune system on these children, and we have to be careful. We monitor this by their neutrophil count. It's like the nadir time. There's another slide that you would see is about nadir. Now, what do we need to know about neutrophils? Neutrophils are the white blood cells that help fight infection that prevent you from getting too sick. Your body tries to fight against it. When you don't have neutrophils, you have nothing in your body to fight infection. So if I had a neutrophil count of 500 and I now have a fever of 101, I'm about to go into septic shock. This will always be your priority patient to see first. So a child with a fever, an absolute neutrophil count of lower than 500, that is a sick child, and again, requires your first attention. What do we do? So you have a fever. We got to find out what it's from. So we do all of our cultures, all of our, cultures of urine and blood and nose and all that. And we'll do blood cultures. And we're going to be starting broad spectrum antibiotics immediately because that child has nothing to help itself. So we take it, find out what that infection was, but in the meantime, we're going to treat them with something to prevent them from going into severe, overwhelming sepsis. Chemo does a lot of different things. Again, it does mess with the platelets. So you're going to be seeing those things going on, the bleeding, the petechiae. Also, blood cells are being destroyed with chemo because not only the bad cells are being destroyed, some of the good cells are also. So again, blood transfusions are going to be given. And we know that these kids under chemo, because white cells, red cells, and platelets are all being attacked, these kids need to be protected from injury, as in they can't be out riding their bikes and skateboards and playing football now because they have, these platelets low, they're going to bleed. They get hit in the stomach, they could just perforate and bleed in their belly. So we don't want those things. So again, making sure we limit their activities. Now, we know nausea and vomiting is part of chemo, making sure we give the medication, antiemetic, before we give chemo. I tell my students, which is crazy, when I first started becoming a nurse and we had our first type of antiemetic medicine, I could not give it till after that patient vomited. And I'm like, it's anti-emetic. We're supposed to give it so we don't. So I used to say to the patient, okay, spit. All right, you vomited here. Here's your medicine. Because I knew that it would help them at that time. So it's a crazy antidotal thing. We know that their mouths get sore. We know mouth to anus, all with mucosal things, irritation. So they don't want to eat. And even they're going to have hemorrhoids and stuff. Again, food should be soft, bland. Again, toothbrushes nice and soft. Again, sitz baths, sitting them there for their anus, if that's where or the mucosal stuff is. Another thing we forget is that these children have pain, so we give pain medicine, right? What does pain medicine do? It causes constipation. These kids have bleeding problems. They can bleed easily. If they bear down too hard to make a bowel movement, they could have a stroke. So, using stool softeners, because that's a true and real condition that can happen if we have them pushing too hard. So again, keeping them with their pain medicines, we need it, but making sure they move their stools, but keeping with it so they can drink and eat at least what they can. We know their urine can have blood where anything else can. And we know chemo. The first thing we think of, I'm going to lose my hair. I can't tell you how many fathers and brothers and uncles and grandpas all shaved their heads with their kids just because. I used to make ribbons. And I would, whenever I went to the store, I would get a big spool of ribbons and I had all the colors. And we'd make rainbow ribbons and this and ribbons, and I'd wear one and they wear one. And again, it made it less of a no hair. It's like I have a pretty ribbon. And steroids. This will always be an issue when you have any type of patient. They do cause a lot of swelling and weight gain. Anybody, kids to adults, can become uncomfortable. So, again, preparing for procedures. Usually bone marrows, yes, they are under sedation. But again, sometimes they're going to understand a little bit with it. So explain it to them. Make sure that they know that you'll do everything to keep it as minimally painful as possible, and that we use the proper medicines for numbing, whether it's topical or deeper, and make sure that the physicians do use it. Pain management, very important. Kids won't ask for pain medicine. They just don't. They don't know how to. So again, understanding, looking at a kid, if they look like they hurt, reposition them, distract them. We know if we do not take and medicate or do distraction or position or use ice or heat or whatever we need to, that pain is going to follow the pathways and create even more pain. And they're going to be even more uncomfortable. Kids and cancer. Can we do normal health care? Can we do dental care? Can we give immunizations? Immunizations is always a question on your HESI. It'll always be there. Dental care. Yes, fluoride, dental examinations. We might see teeth delayed, and that's unexpected. All right. Immunizations. We cannot, any immunosuppressed patient, and this includes anyone on steroids, okay? That's a med surg question. Anyone immunosuppressed cannot get a live vaccine, okay? They need to use inactivated vaccines. Now, family, they can't get all their vaccines either. So again, we need to ask. The biggest, believe it or not, disease that can hurt children is varicella. They have to get that varicella immunoglobulin. That's the one, believe it or not, which will kill children. It's varicella on these sort of children. They don't mention the other ones. It's varicella. Here we go. Hodgkin's and non-Hodgkin's. So Hodge is a lodge, is a house you can touch, you can feel. It looks like that picture up there. It's a big swelling. It doesn't hurt. And yes, they do radiation, chemo, and they excise it and get it out of there. Non-Hodgkin's, as you can see, is little pieces everywhere, but it's nothing big. So it's diffuse. All right. Hodgkin's disease, again, once we get it, it can metastasize. Usually it's that big lump and then it pushes, gets bigger, and starts coughing, which brings parents in, which gets the diagnosis. So this is what we see. Hodgkin's, Hodge, a lodge, a house. I can see it, touch it, and feel it. Okay. It's painless, enlarged, cervical, supraclavicular, above the shoulders, sort of lymph nodes are big. Okay. You will see fever, and you see that pushing against the trachea and the esophagus, which causes anorexia, which causes the weight loss. Okay. So, how do we diagnose this? Well, we'll do all the lab, whatnot sort of things, but it's the lymph node biopsy. And what we'll see is Sternberg reed cells. So, this is a big, big lymph node, right? We need to shrink it before we can take it out. So, we do radiation. We do chemo with or without. I mean, they're all different combinations. And then they do surgery and they do get it out. The one thing about radiation is do not remove those, and they're usually purple, like a blue purple mark, like a magic marker. Do not erase them. That's where that gun goes directly into where they want that node hit with radiation. We know Hodgkin's with all of this therapy. This is a child that's going to have a high risk for infertility as they get older, Hodgkin's. Now, non-Hodgkin's, you can see again, you can't really see it. It's like little pieces, little stuff. It's not big chunks, not big lymph nodes, okay? And again, we do the same sort of thing. Radiation, chemo, yes, we'll try to do biopsy. And we try to take it out and do the cure. And again, it's very similar to like leukemia, the induction, the consolidation, same thing like leukemia, same treatment that we would do because it sort of pieces all over the place. Now, brain tumors. Think about what a tumor is. Tumor is a piece of something, a mass inside the brain, occupying space, getting bigger, pushing on the brain. So you're going to see symptoms. Usually it starts with that's getting bigger. I get a headache because it's occupying space, pushing pressure in there. Sometimes it's headache and vomiting. But the key thing, it gets worse over time. It's not like I vomit with meals. No, I vomit, not related to meals. I get headaches and it's, getting worse, getting worse. It might get to the point of hydrocephalus, your eyes, nystagmus, could be the gait, you're ataxic, it means you can't walk and you're crooked. Um, you have your pituitary gland in there, diabetes insipidus. We'll learn this next week. Growth failure, growth hormones in the pituitary. Again, if it's pushed on there, it can cause issues with that. So, how do we diagnose brain tumors? Well, first of all, of course, it's those symptoms headaches and vomiting, and it's getting worse. And maybe starting the gait, starting to fall over, not walking correct. Those could be those things. We'll do CTs and MRIs and all those things. If it's a brain tumor, we don't do an LP because that mass is in there, it's being cushioned. We take fluid out, it could move it and cause more problems. So we will be doing radiation therapy. We will do chemotherapy and then we will do surgery. We want that tumor to be the smallest it can be before it is removed. Now, post-operatively, brain tumors. You need to read those doctor's order carefully. Do you have them sitting up 90 degrees, 45 degrees, 30 degrees? Do you sit them on their surgical site? Do you lay them off their surgical site? There's a brain drain. Do you empty it? What do you do with it? All those things. And then also fluid balance. We don't want to overhydrate these children, extra fluid in the brain. That's a big one with this one. And of course, we might have removed something in that brain with that tumor. So after surgery, let's try to get that child back to the best functioning, back to normal as we can. Now, a neuroblastoma starts in the abdomen. And before we even know that there's a mass in the abdomen, it's already in the brain. So outcomes aren't good. Usually we don't see it in the abdomen. All of a sudden we start to see things with the brain, as in we start to see in neurological things going on. Maybe we start seeing edema in the eyes coming out, swelling around the eyes, and maybe some neurological, some sort of impairment. It's already to the point where outcomes aren't good. So it's not a great diagnosis. Bone tumors, osteosarcoma. An osteosarcoma is where usually when we discuss these, we talk about the femur bone. Now, the femur bone gets a tumor in it. Usually what we see is a child, usually it's adolescence to early 20s area where I've seen most of them, where the kid is active and then starts complaining of pain around their knee and it gets worse and worse. And then the limping is going on. Then we start to see they can't even hold things and they're falling over, their knee gives out. So, how do we take care of this? Well, number one, they're telling us their knee is getting worse and now they're falling down, etc. We start to look at a CBC. It's a cancer, so probably your hemoglobin going to be low on this one. And maybe with this bone tumor infection, so white blood cells again. CBCs tells a lot. Of course, we're going to do all sorts of x-rays and we'll do a biopsy. Once we look at this biopsy and determine that it is a cancer of the bone, the whole bone has to come out. You can't just chip off the little tumor like you would just chip out the tumor out of a brain. No, that whole bone is infected, which means that whole femur bone must come out. It must be gone. So, what they do, and the goal of surgery, is what we call salvage the limb. They take the lower part of the leg, the tibia and the fibula, and put it up into the hip joint. So now there's something to put a prosthesis on. So now that child can be mobile. And that's why they do it for. Sometimes it has to be a true and real just amputation, but they do the chemo, they do radiation, they go ahead, they take that femur upper leg, they take it, throw it out, take the lower leg and put it up in, and now we put them into therapy with their prosthesis. Okay, here's that Wilms tumor that we had that question on. Wilms tumor is a nephroblastoma, kidney tumor. And I had a little boy. He was 3. He came from Haiti after the Haitian earthquake many years ago. And this religious group picked him up from the airport and brought him to me with his medical records, which were in French. So I couldn't read them. So here I have a 3-year-old boy. They said, we're supposed to bring him here. I had no clue who he was and what to do with him. So what did I have to do? I had to do an assessment. I was the triage nurse. I had to put this child somewhere. And his belly didn't look big and round like that. It didn't look like there was something huge in there. So I had to get down on this child's level in French. I don't speak French. I had to get him comfortable to do an assessment. I had to do vital signs. And then the last thing I did was after breast sounds, I went and listened to and felt his abdomen. On the left lower quadrant, about the size of my hands together, like a big softball, hard, I felt a lump. And I knew, and I do not know how I knew, it was a Wilms tumor. So immediately I put a thing on the chart. Do not palpate abdomen. Went in, told the attending and the nurse in charge. We went, we did our x-ray ultrasound, and yes, it was a Wilms tumor. Now, the thing with Wilms tumor is that they're fragile. Even biopsies aren't done because the little hole in it will make metastasis come out everywhere. I mean, outcomes are good if we do these things, okay? This child within 3 days went to the OR. But the thing is, think about this. We've got a child, we can't palpate abdomen, put signs everywhere. Also, this is a child that during surgery, the kidneys are in the back, which means you have to go through all the intestines to get down to get this kidney tumor out. Ileus postoperatively are huge on these children. Their bowels are angry. So postoperatively, monitor their bowels. And you just took a kidney. So monitor output and always, and you've done all this manipulation, monitor for infection. Now, a retinoblastoma is a cancer of the retina. And it looks like, at night when you go outside, turn on a light, you see an animal and you see the shiny white eyes, that cat's eye, that cat glow that you see, whether dogs, cats, cows, bears, don't matter. They got the white glow. Well, humans shouldn't have it. And if they do, it is the sign of a retinoblastoma. Now, I've seen only one, and it was like a 10 or 11-month-old little girl. And I was like, oh boy. But anyway, you could see, even just looking at her with a shiny light in the room, you could see that white there. So, what they have to do again is radiation. You can see that purple mark. Do not clean it off because that's exactly where they point the radiation gun to shrink the tumor so that they can take out the smallest amount of tissue and making sure they get it all. One of the things with retinoblastomas is how did it happen? We need a history. Was there issues at birth with the eyes? Have there been infections, tearing? Do you see gump in the eyes? Do they see? We want a detailed history regarding their eyes and the symptoms and when they started to see these sort of things. The last sort of tumor we're talking about, boys. Boys have testicular cancer. That's why women do monthly breast exams. Men should do monthly testicular exams. I had an 18-year-old boy come into the triage room and actually was with the nurse that was with me. And, we did our assessment and she went, had to pull his pants down and feel his testicles because it's part of the exam. And the one testicle was the size of larger than a softball and hard. So we sent the kid to the back and they did ultrasound and then they just did an x-ray of his chest and his abdomen. He had already metastasized. He had had that testicle that enlarged and painful for well over a month or two. He was embarrassed to tell anybody about it. So what I found out is that child 3 months later died from testicular cancer. And if he would have came earlier, we could have done something. Liver tumors, livers grow back. So take the liver out and the piece can grow out. Yes, it's still a big surgery, but livers grow back. And today, this is from a book that's been out a couple years. I know that the survival rates keep going up and up with all the new therapies, the new drugs, the new everything, that more and more are surviving cancer and all the treatment. And this is something, on the Facebook or Instagram or whatever you look at, seeing these little pictures of these kids bring me back to some of the memories of some of the kids that I've been working with. So I enjoy those kids. So who wants to win this one? Can you see that? Thank you. Anybody else want to join? I know you're all tired. It's brain dead time. Let's get going. A child admitted with neutropenia. What nursing action takes priority? Again, remember, hand washing will always be. Remember what neutropenia is. That's a vocabulary word. That means low white count, which means I have no immune system, which means you have to be careful with me. That's a word. Remember. Which symptoms would a healthcare professional expect to see in a child with leukemia? Remember, leukemia affects white cells, red cells, and platelets, right? So, what are the symptoms you would see with that? And that's the bruising, fatigue, and bone pain is part of it, yes. A child with Wilms tumor, what action by the nursing student causes that faculty member to intervene? Nephroblastoma. And remember, with anything with a kidney tumor, remember you're always going to worry kidney, always worry about blood pressure. Those are always hand in hand. This would be maybe a child with a kidney problem that might need something for the blood pressure. Your child with ALL has recent lab results with platelet count of 10,000. What's your nursing action? And then I'm going to say any patient that you get that has platelet counts of 10,000, what is your nursing responsibility? What's in your nursing care plan? It's all about bleeding. Okay. You'll see questions like this, whether it's ALL or cystic fibrosis or this or this or that. Low platelet counts, it's the same treatment no matter what the child is. It's all about bleeding problems with platelets low. And what do you look for? Petechiae, ecchymosis, epistaxis, any bleeding from anywhere. A child with ALL has a fever of 100.5. What should they do? Any immunosuppressed child with a fever of 100.5 or greater should do what? And why? They don't have immune system. They're immunosuppressed. So these children need to get medical attention now. Remember, they have no immune system. They'll go into septic shock. They need antibiotics now. Your child's having a bone marrow aspiration. What should you tell the child? Oh, again, any procedure you do on a child that's going to hurt, please be honest. Tell them it's going to hurt. You'll do everything possible that you can. Have anybody ever seen a bone marrow aspiration, whether in the hip or xiphoid process? They take this T-shaped needle and they have like a handle on the top with a needle, and it's a big lumen with a sharp point. And they put it in after they numb it, and it goes, and you could hear it going through the bone. So these children are going to hear these things. So it is scary. Most of the time, they are sedated, though. Most common clinical manifestation of a retinoblastoma. And it's also called a cat's eye reflex. It's that white thing in the retina. And the treatment, they take the whole eyeball out, and that's the treatment. Your child's been diagnosed with a retinoblastoma. What information is important? What do you need to know? So when you have a retinoblastoma, we've got a tumor in there. Now, there might have been things that led up to it, signs and symptoms that gave us clues. So again, these are important things that we need to do for their care. A goal of surgery for a child with an osteosarcoma is. So, osteosarcoma, we're talking about the femur bone, and we have to take that whole femur bone out. We can't just take a piece of the tumor off. No, the whole bone is gone. So that upper leg now is gone. So we have to take the lower leg and put it up into that hip joint so that now we have something for prosthesis. Our goal is to salvage the limb, but if we can't, it will be an amputation. A child's complaining about skin markings for radiation therapy should be told what? So these markings are there because we need to know they take a lot of time to measure out and to mark these things so that they know exactly where to put that radiation gun because they have to put it the same spot every time. We used to do what we call washing off parties, and have a cake and everything. It was a big deal to get those marks off. Again, it's that distraction. Make it less threatening. What assessment question needs to be asked for a child with possible rheumatic fever? So again, rheumatic fever, what is it? Rheumatic fever is due to a strep throat that was treated or not completely treated. What are the signs and symptoms of rheumatic fever? You need to know these things. We need to know that there's polyarthritis. We know that there's rash. We know that there's sore throat, the chorea, the movement that we see with it. And again, heart valve damage. Knowing that if the heart valve's damaged, there's nothing we can do. We just have to treat it medically or surgically. If a child was to receive their own bone marrow, this is called a blank transfusion. How did I tell you to remember that one? Automatically, mine's the best. That makes it easy to remember, doesn't it? What cancer may present with painless, firm, and enlarged cervical nodes? Up here. And that's Hodgkin's lymphoma. Yes, remember, non-Hodgkin's is diffuse. You can't see it and touch it. It's in there somewhere. It's harder to find. Treatment of an osteosarcoma includes so treatment. I mean, our goal is salvaging that limb. We'll do chemo, we'll do radiation. And if we can't salvage that limb, it's going to be an amputation. A stem cell transplant does nothing. We have to take the bone away. Has nothing to do with blood or those things. So it is not a stem cell. No. Sorry. Who are the best donors for a bone marrow transplant? So we know automatically mine is the best, will always be the best, but all the others, allogenic, the best ones are siblings. Can we use moms, grandmas? Yes, but before that, it'd be better mine or my brothers and sisters with the same mom and dad. Those are the best ones to use. Would you consider to be neutropenia or a low neutrophil count in children? And remember, any child, adult, anyone who has neutrophil count less than 500, this is your priority patient. They have no immune system. They're about to go into septic shock. You are going to run all your cultures and start broad spectrum antibiotic immediately. That's what neutropenic means for low neutrophil. A primary characteristic of a brain tumor. What do you see? So again, we have symptoms, but they're getting worse. So it's vomiting, not related to eating, headaches that could even wake them up at night that are getting worse and worse. And that's the whole thing, not occasional. It's getting worse. Headaches worse, vomiting worse. The optimum treatment for an osteosarcoma is, what do you really want? Our absolute goal, what we want. I mean, we don't want to have osteosarcoma, but if we do, we want to be able to salvage that limb. So at least we can put a prosthesis on and get up and out and we can move. And last question. A child is receiving the induction of chemotherapy. What does that mean? Again, induction is that initial intense chemotherapy. That's that first 4 to 6 weeks of it. And the goal is remission. Now, we still have 3 other steps we do just to ensure that there's no little cells hiding anywhere that are going to sneak out and start again. So, again, induction is that initial with the goal of remission. Number 3, SK. Good job, SK. Number 2, you got a tree. Number 1, nah, good job, Jenna. And a me and a Brittany. Now we got a couple minutes. What I wanted to do with you is to go over a mics per kilo per minute question. I think that and heparin questions written in certain ways drive you all nuts. And I don't do ratio proportion, okay? But what I can do is show you how to do it easy that you won't make mistakes if you write things down the way I do. Now, let me give you and I'm going to send this to you too, so that you can work with it. Okay, let's go down to, how about number 7? Let's do number 8. Number 8's good. It's one less step for me to do. Can everybody see that worksheet? Yeah. All right, so number 8, it's that, oh my goodness, mics per kilo per minute question. So when I look at anything in dosage calc, I'm going to look for 3 things. Is it a dose to be delivered? Is it mLs per hour? Or is it drops per minute? And when I look at this, the doctor is saying, I want you to give a dose of 6 micrograms per kilogram per minute. That's your dose. That's your D. What did the pharmacy send up to you? Well, it sent you up 500 milligrams, and that's what you have on hand or available. And the quantity it came in is 0.5 liters or 500 milliliters. So, and this patient weighs 85 kilograms. Let me show you how easy I set this up. Remember, if the dose is 16 units per hour, it's the same thing as mics per kilo per minute. We still have, that's your dose. All right, so I told you we have a dose, and our dose is 6 micrograms. And the kilograms are 85, so I'll just put it in there, and it's per minute. And what do I have on hand? What's available? Well, they gave me 500 milligrams. And it came in, I said 500 mLs. Do you see how I set this thing up? Desire over have times the quantity. So let's look at this. I put the kilogram in there already, but the last thing I see is I've got milligrams and micrograms. So I have to do a conversion. Now, you could make them micrograms, you can make them milligrams. It doesn't matter which way. Personally, my question wants micrograms per answer. That's what it's looking for. I'm going to change my milligrams to micrograms. So I multiply it by 1,000. And that becomes micrograms. This comes away. Now, micrograms over micrograms is one, so that goes away. So my answer is milliliters, but this is minutes. I want hours, so I have to multiply it by 60. If it's micrograms per kilogram per hour, you do nothing. If it's micrograms per kilogram per minute, you have to multiply it by 60. Now, I will always tell you multiply the top and then divide by the bottom now. We've got all the labels correct. Everything's there the way I need it. So let me go to my calculator. And we go 6 times 85 times 60 times 500. And I do it again, just to be sure. 6 times 85 times 60 times 500. Did anybody do this with me?
Yeah, I got 30.6.
And the answer is 30.6 mLs per hour. Did that help anybody take things out and put them together and make more sense? Shelby, did that help you? Okay. I'm not picking anybody out. I'm just making sure everybody gets it. Now, I want you to also look at this question because this is the other question I see you all not liking. And I know you have these, you're going to be seeing these in med surge. Even I've seen these in management. You see, I think I have one. Okay, number 9. I have an order of 100 units of regular insulin, 250, and I'm going to fuse it at 12 per hour. And what is my mLs per hour? Again, it's a dose. They want me to give what as my dose? They want me to give 12 units per hour. And how much did they send up to me? What's available? What do I have on hand? 100 units. And how much did it come in? It came in 250 mLs. And I don't care what fluid it came in. It's just it came in fluid. So let's go back and set that one up, and then we'll be done for today, guys. I just wanted to get this because it's something that I've seen. Find another board. Okay, so this one had 12 units per hour. That is my dose. It came in 100. units. And that 100 units was in 250 mLs. And that's going to be my answer. Multiply and divide. That's how simple heparin questions are. Whether it's 550 units and it came in 5,500 mLs, it doesn't matter. It's always set up. It is a dose. And what do you have on hand? And what's the quantity it comes in? So 12 times 250. And if you'll notice, I'll always do it twice. If I get the same number twice, I know I'm doing good. Divide it by 100. And our answer is 30. Does that help everybody? All I'm going to do with you today. I just thought it'd be something that can help you if you're lacking in that one. Anybody have any questions about anything? That's all I got, guys. Anybody who wants to meet with me before the exam, let me know. If you're having problems with concepts, let me know. I'm here to help you, okay? Have a good afternoon, guys. Bye.
Thank you.
You're very welcome.
Thank you.